Welcome everyone to today's virtual policy forum, Public Health and the Delivery System, Vital Connections. We're so glad that you could join us for the second conversation in our series, with today's theme being Building a Stronger System for the Future. I'm Cecilia Oregón, or Ceci, the Executive Director of the Kaiser Permanente Institute for Health Policy. And at the Institute, we host events and publish information to shape policy and practice on important health topics. We often convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible, high-quality care. With that mission in mind, we are hosting this forum to discuss public health and the delivery system. As someone who started her career at Alameda County's Public Health Department here in California, I'm pleased to open today's conversation. In the upcoming panel, we'll hear from leaders who will both reflect on the challenges in our public health system, many that were laid bare during the pandemic, and consider how we might learn from current experiences to build and sustain a better, more prepared public health system for the future. But first, a few quick housekeeping tips. During our panel, we'll take questions from the audience, and you can submit questions through the Ask a Question box on your screen at any point during the forum. And we'll also be pulling in questions from those that were submitted before the event, but we might not have time to get to every question, so we'll do our best. If at any point you experience technical difficulties, please let us know, again, using the Ask a Question box. This event is being recorded, and the video will be made available on the Institute for Health Policy's website in the coming weeks. So on to today's content. In this conversation, our esteemed panel will speak to the importance of a strong, well-funded public health system, reflecting on the many challenges and lessons that have emerged throughout the pandemic. We know that in order to respond to future public health crises and support long-term community health, we need a strong, well-funded system. Yet the public health sector has long faced structural and financial challenges. Today, we'll consider how we can support an effective public health system and how we might foster stronger connections between public health and the delivery system moving forward. On Monday, we heard from delivery system and public health leaders, including our own CEO, Greg Adams, Dr. Barbeau, Patty Hayes, Dr. Perotti, and Dr. Rainey, who shared their experiences responding to the pandemic. Many important challenges and lessons learned were raised. The speakers pointed to the need to improve messaging and communication between healthcare and public health systems, as well as to the general public, to rebuild trust in the system, to build upon relationships between public health, the care delivery system, and businesses. We also talked about the need to collect data and improve information exchange in a bidirectional way. We heard from more than one speaker about the use of fax machines to share information between health systems and public health departments early on in the pandemic. And we also need to keep thinking about our frontline staff, keeping them safe, keeping them healthy, and especially now while they're dealing with high levels of exhaustion and burnout. And we don't want to lose sight of the other challenges that we're experiencing right now with exacerbated mental health issues, addiction, and certainly challenges related to people making the decisions or needing to defer care. And critically, across all of these areas, we need to address racial equity and elevate leadership from communities disproportionately affected by public health challenges, including communities of color. So I'll now turn us to today's discussion. To get our panel started, I'd like to introduce our moderator, John Auerback. John Auerback is the Director of Intergovernmental and Strategic Affairs at the Centers for Disease Control and Prevention. In his role, he's the lead strategic advisor on CDC engagement with government agencies at the federal, state, local, tribal, and territorial levels. Over the course of his 30-year tenure, he's held as senior public health positions at the federal, state, and local levels. He's served as president and CEO of Trust for America's Health, an associate director at CDC, the commissioner of public health for the Commonwealth of Massachusetts, and Boston's health commissioner. In addition to his government service, John was a professor of practice in health sciences and the director of the Institute on Urban Health Research and Practice at Northeastern University. He was also the director of the largest Women, Infants, and Children program in Massachusetts. We're so thrilled to have John lead our panel discussion, so I'll turn it over to you now, John, to introduce the panel.
Well, thank you so much, Ceci, and thank you to Kaiser Permanente for focusing its attention on this important topic. You're doing so at exactly the right moment. This is a moment that's filled with the evidence of the consequences of neglecting the public health system. In the past 20 months, we've seen and are continuing to see the cost in hundreds of thousands of lives, in the health of many millions of people, and in the well-being of virtually everybody in this country. And we've seen the disproportionate burden imposed by racism, by poverty, and social and economic conditions which elevate the risk for historically marginalized populations. But this is also a time of enormous opportunity. Policymakers are paying attention to public health and making unprecedented resources available. CDC is going to be releasing a $3 billion grant opportunity to build the public health workforce in the coming months. $500 million will be spent to upgrade the data information systems of the public health sector in the coming months. And there may well be funding for public health infrastructure in future federal budgets. And we have forums like the one today where people are debating what needs to be done that will be meaningful, sustainable, and focused on upstream approaches. The more and more people who believe that the solution doesn't just reside in incremental change, by which I mean limited increases in funding to the public health system, so it just looks like a somewhat better version of what it did in the past. Rather, there's a growing belief by many in the public health sector that this is a time for transformative change, that we need a public health system that's nimble, able to focus on what's needed to address key health issues, paying attention to strong partnerships, staffed by a highly skilled and well-treated workforce, utilizing modern data systems that are both timely and accurate, and also that tap many different data sources. We also need a myriad of communication capabilities that can function 24/7. And we need policies, programs, funding, and staffing that reflect a deep commitment to equity and justice. But we have to take advantage of the opportunities. They won't last forever. Our panelists will help us understand how to take advantage of those opportunities. They have been on the front lines of this effort, and we're fortunate to have them join us. So at this point, I'd like to bring our panelists onto your screen. They are Anand Parekh, who's the Chief Medical Advisor at the Bipartisan Policy Center, Mary Pittman, who's the President and CEO of the Public Health Institute, and Lauren Smith, who's the Chief Health Equity and Strategy Officer at the CDC Foundation. Each of them is an expert in the field of public health and health policy. Each will offer their perspective about where we are right now, drawing from some of the themes that were raised on Monday. But their major focus will be on where we need to go. After hearing from each of the panelists, we'll engage them in a discussion, and that discussion will include you. So please enter your questions into the chat at any time during the panelists' presentations. And in fact, some of you have already done that. You've submitted questions, and so we'll use some of those questions as we move to that portion of the event. So let me move on to our first speaker. He is Dr. Anand Parekh. He is Bipartisan Policy Center's Chief Medical Advisor, as I said, and he provides clinical and public health expertise across the organization. And prior to joining the Bipartisan Policy Center, he served as the Deputy Assistant Secretary for Health in the U.S. Department of Health and Human Services. He's a board-certified internal medicine physician, a fellow of the American College of Physicians, an adjunct assistant professor of medicine at Johns Hopkins University, and an adjunct professor of health and management and policy at the University of Michigan School of Public Health. So Anand, let me turn things over to you.
John, thank you so much for that very kind introduction. It's great to be with you and great to be with Dr. Pittman and Dr. Smith as well. I want to thank Kaiser Permanente and the Institute for Health Policy for convening all of us on this just very important and timely discussion about connectivity between the delivery system and public health. I want to spend just a couple of minutes today discussing one report that was unveiled just a few hours ago from the Bipartisan Policy Center's Public Health Forward Task Force. This was a task force of 14 individuals, elected officials, and multi-sectoral leaders who articulated a 5-year vision for governmental public health in the United States and an actionable framework for state and local elected officials and public health officials to achieve that vision. The work is really built around a framework that centers health equity and advancing health equity to ensure that all Americans have the opportunity to attain their highest state of health. This is work that has been ongoing for the last 6 months or so, led by a coalition of national public health associations as well as philanthropies. And the question of why now, I think all of us could probably answer that. There has been, as John has said, a significant infusion of funds that has gone or that is going to the public health system. It's critical that we leverage that funding. It's not the long-term sustainable investment that public health needs. We'll talk about that, I'm sure, a little bit later, but it is still a critical opportunity. We've also seen, unfortunately, the politicization of the pandemic. And while public health has been in the news and people are talking more about public health, it's not always for the right reasons. And so this is an opportunity to, in many ways, take back public health, to educate the public and policymakers about what public health is, to transcend politics. And so that was really the impetus for this project, Public Health Forward. Again, focused at the state and local level, realizing that, of course, the federal government, the private sector, non-governmental organizations have a huge role to play in ensuring that we advance public health in our country. But there's a particular opportunity right now for state and local elected officials as well as public health officials. I hope that all of you will get a chance to review that report. It can be now found at bipartisanpolicy.org. And I think it's an opportunity for policymakers to review all of the investments that are coming down to states and localities right now, prioritize the recommendations that meet particular jurisdictions, and then work with public and private sector partners to implement those recommendations. With respect to the interface between the delivery system and public health, I think that the report really touches on many aspects of that. And one of the themes really is public health is not just public health responsibility, it's everybody's responsibility, including the delivery system. And so I think when we think about sort of governmental public health and delivery system connectivity, with the continued acceleration of value-based healthcare transformation and alignments in terms of the incentives of what the delivery system is trying to do and what public health is trying to do, I think that there are a lot of opportunities. And in fact, I think the first part of the forum, the initial discussion brought a lot of these topics to light. The first is, of course, data. We talk about the data infrastructure on the healthcare side a lot. Public health data is in many ways a bit more even antiquated. And so ensuring that there's bidirectional information flow between healthcare and public health through electronic case reporting, through ensuring that demographic information that is collected through healthcare is then transmitted to public health. All of that are critical opportunities for governmental public health and the delivery system. A second opportunity is, of course, whenever the delivery system is embarking in community health needs assessments and implementation plans to improve community health, governmental public health really needs to be at the table, working hand in hand with the delivery system to improve community health. And then finally, with respect to health equity and health disparities, as much as the delivery system works at trying to reduce health disparities, until it works with the community and the public health to reduce the underlying health inequities, it's very difficult to really address ultimately those health disparities that we see on the healthcare front. And so I'm sure we'll talk about many of these, but I think this is the right topic. This is the right time for the delivery system and public health to start not just talking about it. We've been talking about this for a long time, but now it's really a time for action. And again, I commend Kaiser Permanente for really convening all of us and rethinking in this moment of national crisis with the COVID-19 pandemic. It's time to rethink exactly how we can improve the connectivity between the delivery system and public health. So, John, I'm really looking forward to the conversation. Thanks.
Oh, thank you very much, Anand, and congratulations on the release of that report, which I think we're all eager to read. Next, we'll hear from Dr. Mary Pittman. Mary is the CEO and president of the Oakland-based Public Health Institute, one of the country's largest and oldest independent nonprofit public health organizations. At the Public Health Institute and throughout her career, Mary has been a nationally recognized leader in improving community health, safety net, and Medicaid provision of care for vulnerable populations, addressing health equities, building the public health workforce, and promoting prevention. Mary's an expert and an advisor in the field of population health, and she's a leader in efforts to revision how diverse stakeholders can work together to build healthier communities, stronger hospitals and public health systems, and importantly, more strategic investments in community health. Welcome, Mary. We look forward to hearing your comments.
Thank you so much, John, and thank you to Kaiser Permanente for hosting this really important conversation today. As Anand said, it's very timely. I also want to thank my fellow panelists, Anand and Lauren, for the comments that they're going to share with us as well. When I think about what we need for the public health system of the future, I think about what we've learned from past public health crises. For example, yesterday was World AIDS Day. We learned a lot from that, but we've learned so much more during the COVID-19 pandemic. During the first months of the pandemic, the Public Health Institute was able to swiftly pivot our infrastructure to partner with local health departments in the Pacific Northwest and to develop a new model of contact tracing that emphasized trusted community voices, those who had lived experience and the necessary language and cultural skills to be able to effectively serve as contact tracers. The success of this model and our ability to rapidly respond to outbreaks, including at food packing plants and other business venues, led to our work with Kaiser Permanente to implement a similar model in California. And we built off of the clinical expertise of Kaiser Permanente and their engagement, as well as connecting with the local health departments and community clinics. Tracing Health had 240 contact tracers in California and 155 in Oregon and Washington, and they effectively supported county health departments and clinical systems. It was somewhat a unique model in that connectivity. The combination of working with governmental public health, the state and local health departments, Kaiser Permanente, and community clinics, as well as community-based organizations, gave us a unique vantage point to understand what was happening in the COVID pandemic and really where the leverage points existed to intervene. It also helped me really crystallize what we need moving forward to make our public health system and our overall health system stronger. Community-based organizations have played a critical role in this pandemic. They strengthen equity and justice, and they're extending the reach and capacity and effectiveness of every part of our COVID-19 and prevention and vaccination effort. Many have referred to community-based organizations as partners in this work, but community-based organizations are more than partners. They are an integral part of the public health ecosystem, and we need to think about how do we shift resources, power, decision-making, and different ways of thinking about community-based organizations in our next steps of building that important link between healthcare and public health. During one of the conversations on Tuesday, the panel highlighted the need to build trust with communities, and most particularly among communities that have experienced systemic racism. I want to say that the community-based organizations are those trusted messengers, and they're key. We've worked with over 2,400 CBOs around the country now, and they know how to address the barriers that exist for individuals. They're working in more than 50 languages, and they know how to reach difficult populations that are difficult to reach through normal channels, normal meaning our governmental systems. We often talk about the three-legged stool, but there are really four pillars that can effectively support public health infrastructure: healthcare systems, governmental public health organizations, community-based organizations, and the glue, which we have seen, which are the nonprofits, organizations like PHI and many others who can serve as critical connectors. We all have a role to play in public health, and we work best when we work together. That's why my first recommendation is that we ensure dedicated funding streams and direct support for CBOs as part of our public health infrastructure. In California, we are championing a Health Equity and Racial Justice Fund that has been promised to begin in 2022. It would provide $200 million every year to local health jurisdictions across the state, and another $100 million that would support community-based organizations. Second, we need to start building the workforce of the future, a public health and clinical workforce that looks like, speaks the languages, and understands the needs of the communities it serves. This interrupts the medical racism that exists, and it means better care, and ultimately it means better outcomes and lower costs. We do that by lowering barriers to entry into the field. For example, we don't always have to have a college degree to be effective in some of the public health jobs. We have certainly learned that through our contact tracing program. So if it's not necessary, don't put it as a barrier. And for those who are seeking a degree, make sure that you're counting their lived experience as an important part of consideration. And make sure that we are also providing the wraparound services that are needed, particularly for people who may not have had some of the advantages, economic advantages in particular. The Department of Health and Human Services has promised $240 million for a new program focused on education and on-the-job training to build a pipeline of public health workers. And I think that that is something that's very exciting. And community-based organizations, health centers, and faith-based organizations need to be part of that pipeline. We need more of this kind of programming to make sure that we're getting the qualified public health leaders for the future. Without a renewed commitment to building and expanding the public health workforce, we will not achieve our Healthy People 2030 goals, and we won't be ready for the next phase of COVID-19 or the next pandemic. Third, as Greg Adams mentioned in his remarks earlier this week, we must make upstream investments in the social determinants of health. Clinicians have to address the social determinants of health. They have to understand the housing, food security, and safety issues of their patients. And then they also have to be able to connect them to the community assets that are available. One promising model of this is Common Spirit's Connected Community Networks. The networks, including Kaiser Permanente, rely on trusted community conveners and a shared technology platform to connect community partners who help individuals with their housing, their mental health, nutrition, and other needs. This is why the Public Health Institute has joined others in calling for a comprehensive Federal Health Equity for All Act. This is modeled after the Ryan White Act that we know is effective. It would drive cross-cutting government investments at the national, state, and local level to address racial and health equity. It includes funding a health in all policies program, which we've had in California, and it has worked effectively. We now need to scale it on the national level. And finally, I won't go into any depth because I think Anand has covered it well, is that we need better data systems, and more connected data systems, including telehealth. So what I'd like to just end on is saying that the lessons that we have learned, whether it's from community-based organizations, local health departments, or from the healthcare system, is that we all have assets to bring to the table. So when we look at the future of public health, conversations like the ones that are being hosted are absolutely critical And then we need to put the work groups together to make sure we implement. Thank you, Jim.
Well, thank you, Mary. And thanks for offering those concrete and specific recommendations. And I think when we get into the discussion, we'll have a chance to dive into the different topics that you've mentioned. I think those really resonate well with the report that Anand was releasing today as well. So a lot for us to get into. But we're looking forward to our final panelist now, and that is Dr. Lauren Smith. Dr. Smith is the Chief Health Equity and Strategy Officer for the CDC Foundation. And in this role, she partners with the CDC Foundation's other senior leaders to develop and drive strategic efforts to embed health equity across the foundation's COVID-19 response activities, with an explicit focus on addressing systemic racism and its impact on the resiliency of vulnerable populations amidst the pandemic. And previously, Lauren was the co-CEO of FSG, a social impact consulting firm, and she served as the medical director and interim commissioner for public health at the Massachusetts Department of Public Health. So Lauren, it's great to have you. We look forward to hearing you.
Thank you so much. And I want to echo my colleagues in really recognizing and applauding Kaiser Permanente for convening this conversation. And I think that the focus of being in a place where we can have conversation and thinking about these issues, but also how we pivot to action and how we pivot to doing something differently, I think is really important. And I'm excited to be part of that conversation. I would just want to add or offer a few reflections on where I think we are now. What are some of the issues that we're going to have to confront in order to move out of this kind of situation that we're in an effective way? The first I would say is I've begun to think about this situation as a crucible moment. And by that, I mean, a crucible moment is one of intense challenge or strain in which, elements go into the fire in the crucible, and then they emerge fundamentally changed into something new. And I think, Mary pointed, and both Mary and Anand pointed out very well, that the experience of COVID-19 has really indicated that what we had before wasn't working, and we knew that it wasn't working, and we could predict how a pandemic would play out, and it did. So what we have to do is to develop a different way of going forward, not just to recreate or to get back to what we had before, since unfortunately that wasn't working for so many. I wanted to just respond also to one of the themes that I think came up in the prior conversation, which was about the need for equitable response and recovery that acknowledges the persistent structural challenges and barriers to community health and well-being. And I know we're going to dive into that, but that idea of the acknowledgement and the reckoning with what we in public health as well, and as in healthcare, I'm also a clinician, so I consider myself part of that field as well. What has been the situation that has led us to be in this persistent place, knowing that so many of us have been, working to address this for so long? The second issue I wanted to sort of reflect on was just how much people have stretched. And I think, again, both Mary and Anand have mentioned this. Over the past 20 or 21 months, people have really stretched. They've expanded their thinking. They've begun to do that reckoning and acknowledgement in places that maybe hadn't done so before. But now I think we're beginning to see a bit of fatigue, a bit of weariness with some of that, not just weariness and burnt out and exhaustion from being on the front lines of public health, but from having to sort of confront these challenging conclusions about our systems that are deeply uncomfortable to recognize. And so there's a tendency, I think, among our in our field and sort of in our society more generally to want to snap back to what was comfortable and familiar before. And so we need to be very aware of this phenomenon and be intentional in terms of how we counteract that in ways that will allow us to build the kind of resilient and vibrant communities that we want to do by continuing to challenge and doing the uncomfortable work that we have begun. We've come too far in the past 20 months to sort of backslide and allow ourselves to sort of snap back into those other perhaps more comfortable but not effective sort of situations. I wanted to also pull on a thread that Mary mentioned about expanding our definition about what counts as public health and what skills and capacities are needed in order to practice public health effectively in the future. And I think you mentioning the connections with community-based organizations and the ability to develop authentic and bi-directional, mutually agreeable and productive relationships is an example of that. But there's a whole host of other things that really our public health officials, some have, but others, will need support in order to grow those, such as the ability and the experience in applying equity principles across all stages of the data lifecycle. Both Mary and Anand mentioned data and the idea of how you decide what questions to ask, where to go, how to involve community in a meaningful way throughout the whole process, not just in the data extraction process. For many communities, that's what it feels like. It's an extractive process. We go, we take information, and they don't see us again. So how do we do that, in a really very different way that contributes to the next topic I wanted to mention, which was galvanizing public support through shifting the narrative, developing different narratives for public health. We need to be even more sophisticated in how we discuss and convey the essential role of public health. So much of what we found out during the COVID pandemic is that people don't have an idea or don't have a accurate, incredible idea of what public health is and our role and why we're so important. I think, the analogy is no community would wait until houses are on fire to build and staff and train a fire department. It sounds absurd to even say that. But in a lot of ways, because of the decades of underfunding of public health, we've decimated it to the point that that's sort of what we expected to do during a crisis or a pandemic. So we need to work on that and why it's essential to build that public support. So I'm hopeful that in our conversations that we're just about to have, that we'll be able to dig into these pieces around how we can be sure that we don't snap back to a process or an approach that wasn't serving many of our communities well. And how can we go forward in building that kind of deep support for public health to be able to do the kinds of investments that we know are necessary and need to be sustained?
Well, thank you, Lauren, for raising such important questions and thoughtful questions. And I think that will, those issues I think will come up now as we get a little bit deeper into the discussion. It's clear from the discussion that took place on Monday and also what the panelists have just highlighted already, that there's both a lot of challenges, a lot of opportunities, and just a lot of issues for us to dive into. And so I want to start out by diving into an issue that maybe it's the hot topic now, and that has to do with infrastructure and what we mean by public health infrastructure. There's, I think, as has been said, we never used to talk about public health infrastructure, and now that is getting a lot of attention, including from members of Congress. And so I guess I'd like to ask each of you, what are we talking about when we're talking about the need for a strong, durable, resilient public health infrastructure so we're ready for future pandemics? When you hear that term, what do you think of? And what do you think is the most important part of an infrastructure for us to pay attention to. And by the way, this is going to be a discussion among the three of you. So I'm not going to direct a question to one person, but I really hope you all dive in to the extent that you have some thoughts about this. So any one of you, please feel free to start.
Well, I'll start, and I'm sure my colleagues will add on. We've heard many, many times data, and certainly most local health departments, and I would say the connectivity between state and local health departments are antiquated. Our data systems can't talk to each other well. We saw that just in the exchange of data with contact tracing. We couldn't always get a quick turnaround so that the tracing could happen. But it's beyond that. In some places, we have data and we don't have people trained to utilize the data. And so we need the professional workforce to be able to analyze the data, to use predictive analytics. And I would say we also have to make sure that that data is transparent and accessible to the community. I talked a lot about community-based organizations. Sometimes our data is delayed, and by the time you get that data, if you go out and talk to people in the community, you find that the whole premise that you're operating from has changed. So you have to be able to collect the right data. It has to be granular. It has to include the social determinants of health, and it has to be cognizant of race, ethnicity, language needs of the communities. And then making sure we have both the right workforce and the relationships to understand what that data is telling us.
Okay, that's a great start. So data definitely is a topic we're going to want to talk about. Maybe before we move to other aspects of infrastructure, other thoughts about the importance of data, and particularly where you see opportunities for us to do something differently now that will strengthen the data systems.
I think that, totally agree with Mary with what you were just saying. And I think that that's part of what I was alluding to as an example in terms of applying robust equity principles across the entire data lifecycle and not making, I think, what is a common sort of misstep, which is to come in at the end and then to involve community, or to at that point when you've already really narrowed what you're going to be able to find out based on the questions you ask, how you ask, what you were even emphasizing in terms of a priority. And certainly the piece around sort of meaning making. That is, what is the data, or what is the data actually show, and then what do we do with it, and what, how do we apply it? It's a whole separate sort of issue. So I totally concur there. I think the other thing about data and the interoperability, Mary, you mentioned, I think, makes sense too, is how do communities know what data is available, and what do we understand to be rules around who owns the data and who can control how it's used and how it's described, and how are we doing in terms of ensuring that there's not a deficit approach to the way data is talked about, and that it's that there's an element there of having an asset-based approach and recognizing that communities have strengths and not only deficits.
And I'll just add to what Mary and Lauren were saying. I think data is a great example when we talk about public health infrastructure. And I think we've seen on the data front the dearth of data on race and ethnicity when it comes to COVID-19 testing as well as vaccines during this pandemic. As has been talked about, I think we need a bidirectional flow of data from local to state and federal public health. And then we need that bidirectional flow between healthcare and public health. And I think often from a policy perspective, what is it that we need? And I think what we need is we first need to define what is a core public health data set that we can agree on. Then we need standards for that data set. And then we need some funding and accountability to ensure that public health at all levels is able to collect, extract, and share that kind of data. And on the healthcare front, we also need incentives and requirements to ensure there's reporting of the important demographic data we need to reduce health disparities and inequities, that electronic case reporting is occurring. So the delivery system is getting information to public health. And so I think it takes a number of things. I think it takes policy. I think it takes some funding. But that's just a great example, I think, John, of data, of one aspect of public health infrastructure. And maybe this leads to your next question, but essentially, again, anything that is critical to tackle any public health challenge, whether it's COVID-19, whether it's the opioid crisis and mental health, whether it's diabetes and obesity, what are those critical capabilities like data that are necessary irrespective of the public health challenge or threat in front of us? That's what it means to me when I think of sort of public health infrastructure.
Now, can I build on that last statement? Because you really talk to the fact that we don't need just siloed data systems, that deal with COVID or deal with, drug overdose. What we need are much more integrated data systems, which is part of the barrier that I think we have now. We were fortunate in California. We had the Public Health Institute, Southern California Public Health Alliance, which is built from the health directors. They identified this health gap years ago and developed a tool called the Healthy Places Index that served as the basis for a statewide equity metric, so that when we were dealing with the pandemic, that was used by every county to determine how resources were allocated. And when they moved from one tier to another, looking at the most disadvantaged quartile of people living in that community. That was really a hands-on implementation, and everybody knew what it meant. The business leaders knew because it had relevance. And so I think we also have to learn, how do we come up with data that we explain to the general public that has relevance? People know what the S&P 500 metrics are, but they don't know what the Healthy People 2030 metrics are. So I think we have some education to do as well.
And Mary, I was just going to jump in. I totally agree about the avoiding the siloization of data, and also the need to connect data that comes from really different sources. So the clinical data, which is at the individual level, you need a repository or a place where we can connect that and look for patterns with data on housing conditions that comes from HUD, or data on educational attainment that might come from the Department of Education. We need a way to pull in those data sets in an effective way across those silos, because we know all of those things interact at the community level.
So let me just ask one follow-up question before we move off of data. If you're, we're being hosted by Kaiser Permanente, who, let's face it, does the most innovative work in terms of thinking about the connection between clinical care and community health. If you're looking at a Kaiser Permanente or other healthcare organization that is interested in working with the public health sector and thinking about data, well, what are your recommendations for the healthcare system in terms of its relationship to public health when it comes to data?
Well, I think one of the things that comes to mind is trying to understand what the gaps are right now, or the deficiencies in the current system. So, is the delivery system able to transmit, for example, data to local or state public health departments? Is the delivery system able to ensure that important demographic information gets to local and public health? What are the barriers there? Do states and the state legislatures need to get involved and pass laws to allow that type of information exchange? Are there other kinds of technological issues? Are there privacy related issues? And so I think maybe the first thing would be to understand what are the barriers preventing that type of exchange of information? I think healthcare and public health know it's important to transmit information, but there are certainly barriers, and identifying those barriers might be the first step.
Thanks. Well, let me move to a different topic that I think is often included when we're talking about infrastructure, and that is having a highly skilled workforce. Doesn't necessarily mean, Mary, that they've gone to medical school or nursing school. Highly skilled can be knowing their community very well, but highly skilled in terms of the tasks at hand. We do have an opportunity now, as I was saying. There's new funding that's coming from the federal government to pay for workforce. We have a workforce that's been hard hit by the pandemic, both in terms of just the magnitude of the work and in terms of the public response in many communities. It's been harsh against public health. Where do we need to go in terms of the workforce? Where do you see some of the key places that you would say, let's pay particular attention to this aspect of building a highly skilled public health workforce?
Well, I'll jump in. I think Mary already touched on one, which is facility with data, all aspects of it, across the whole life cycle. I think another area I would bring up is and public health has generally been used to doing this, but I think we have to sort of challenge ourselves to do it in a different way, or an evolving way, which is around community partnership and engagement, and to do that in a way that's truly authentic, not just informing community, but being attentive to the power dynamics that come from working in a government agency and going to communities who have had differing kinds of experiences with government agencies. So how do you do that? How do you encourage that in your staff? How do you encourage that in your funding mechanisms, your funding approaches, all those different ways of how you show up in the community and how you can engage with community in different ways is another example of different skills.
I think it's really critical that we focus on new communication skills. Public health, it sometimes uses the moral high road and the science as their lead to their communications. And we have to realize that there are competing values and value systems, and we have to understand how to communicate so that we can bridge different audiences, different value systems. And that doesn't undermine the science. But if we do a better job of educating people on what public health is about and building a collective community public health understanding, then I think it'll be a lot easier for us to have regular conversations with business leaders, with elected officials, with the local community. I think too often public health stays inside their box, if you will, and they need to be out communicating with people on a regular basis, not wait until there's a crisis. Crisis communication is one thing, but you have to have those relationships and the facility to be able to communicate with people about what you're doing day in and day out. And, the other thing is, in the political process, all you need is a 51% majority. When it comes to a pandemic, 51% is not enough. So you can't just pick and choose a few parts of the community to talk to. You really need to talk to all sectors.
Yeah, I wholeheartedly agree with Mary and Lauren. Couldn't agree more. The first assistant secretary of health that I worked for over 15 years ago now sort of reminded me about something at the time I thought was very elementary, but I've always sort of kept in the back of my head. He often used to remind me that public health is made up of two words, right? And it's the second word, health, that we spend a lot of time on. The science, the evidence, understanding from a policy perspective, from a service perspective, what works, how to improve health. But public health also has that first word of the public, and how imperative it is for us in public health to ensure that the very public that we're trying to serve, that we understand their aspirations, their perceptions, meeting them where they are, understanding where they are. And I think, to Mary and Lauren's point, this is a time not only to educate the public and other partners about what public health is and what public health does. It's also an opportunity to partner and build trust with the public. And we do that by remembering that we really need to go out and better understand the public we're trying to serve. Ultimately, that will help us optimize health in this country.
It also calls for those trusted community messengers to be our partners in doing that.
I'm thinking back to the discussion that took place on Monday when the topic of workforce came up, and one of the real concerns that was raised then was how we support both public health and, for that matter, healthcare and its workforce, given what they've been through in this pandemic. We have, a significant amount of burnout, demoralization within the workforce. And I guess I wonder your thoughts about that. How do we help the workforce recover? Where there's some concern we're going to lose people from the public health sector and maybe from the community public health organizations if they feel like this is such a difficult profession. Clearly, that's the case, I think, in the healthcare delivery system as well. So as we're thinking about workforce, what are your thoughts about that? How do we recover? How do we build a more resilient and supported workforce?
First of all, I think recognition that it has been a very tough time for frontline healthcare providers, for people in public health, people in every sector. And so I think first we have to have a little bit of gratitude for what they've done and show that gratitude. I think we have to have a bit of space for people to recover. And if that means extending some additional time, you can't expect people to continue to work at the pace they have and not hit burnout. We also have to protect people who have had the general public lashing out at them. We have to realize that while they're trained professionals, for some people, their lives are being threatened, and that's not acceptable, and that adds a whole other level of stress. So we have to protect them. We have to give them some space to take time. We have to compensate people adequately. If you take a look at the salary levels for some people in public health, they're well below what they might be able to earn in other areas. So their dedication to the field can get tough to maintain when they have all these other forces. I also would say I went to school on a public health traineeship. I have to say that the new graduates that I'm talking to are excited about going into public health. So I think we also have to be nurturing that next generation and help them pay for their education.
Yeah, I think that pipeline issue is really important, Mary. The data I can suggest that applications to public health school enrollment, have gone up, as people have seen this as a really exciting career. So that's really important. And that's one of the reasons I also mentioned about sort of galvanizing public support. It's sort of the opposite of, picketing people's lawns and, following their children to school, that kind of thing. But I think it's the acknowledgement and recognition, but as part of it is the explanation of, in advance of a crisis, what is public health doing and why it is important, because so much of what public health does is, when it works well, it's invisible to the rest of the community. And so they're not aware that it's there. And so it's hard to get excited about what you don't know about or what you don't know is protecting you.
Yeah, I couldn't agree more. I think we use sort of the term public health. We're all in public health. We work in public health a lot, but for the the average person, if you go in America and you use the term public health, they may not know what you're talking about. But if you say, clean water, or you say clean air, or you say infection control, or you say smoking cessation, or you say injury prevention, and you go down the list, I think they have a much better idea of the role of public health, how important it is. And again, I agree with Lauren that just helps the understanding with the public, helps galvanize them to ensure that public health doesn't get demonized and public health doesn't get politicized.
Let me shift gears to another important aspect, I think, of the work in public health of the future, and that is strengthening partnerships. We've had one of the listeners to this webinar ask the question about why is it so important that we should be encouraging strong and lasting partnerships between public health and other sectors, including the healthcare sector. Is that central to building the public health sector of the future, the system of the future, and which sectors are the most important?
I think it's foundational that we have these community-based organizations and other sectors working together. We found that the faith community was, in some places, the most effective spokespeople to get recognition of the value of vaccines. And we've seen that in many different cases over the years, that the faith community can be strong partners in public health. Community leaders are experts in lived experience and understanding what the problems are. So they can both help us understand what the solutions are, and sometimes they can help us prioritize. Our priorities are not always what the communities are. And if you don't address their priorities, if they're hungry and they don't have a place to live, expecting them to pay attention to our public health priorities may not resonate. So I think that's important. We also haven't lifted up the issues in rural areas. And so often the rural public health folks are wearing 2 or 3 hats, as are the community members. So I think we really need to provide additional support and resources to build those relationships, and where people are stretched thin, to augment what's already there.
So Mary, you've talked about that. You really were talking about a lot of it is grassroots work, really getting to work with the community and the community organizations. Do other sectors come to mind as key to building the strength of the public health system?
I can add a few. Certainly, I think housing, nutrition, and transportation to me are central. And then other partners, Mary mentioned the faith-based community. I think business and healthcare, of course. I want to just spend a minute on business and then primary care specifically. But we've done a lot of work at the Bipartisan Policy Center, as others have as well, looking at the value proposition between businesses and public health to improve community health. And there's a lot of alignment here, a lot of opportunity there. Where those two sectors can work together and really conquer issues related to trust and resources, et cetera. So I think that's one particular one to highlight. Within healthcare, I can't think of any more important relationship that needs to be strengthened, and we've recently written about this, than between public health and primary care. Talk about two of probably the most important sectors. Out of the $4 trillion we spend on health in the United States, public health gets roughly about 2%, and that's generous. Primary care only gets about 6 to 7%. These are the two most important sectors to improve health, that focus on prevention, focus on population health. The synergies there, we recently talked about it with respect to COVID-19 vaccination, but there's so many areas there to leverage partnerships between public health and primary care. So I think that there are a lot of opportunities. I think partnerships with sectors and with specific stakeholders are really ripe.
And Anand, let me just ask you a little bit of a follow-up question there. In terms of that partnership you were mentioning of healthcare and public health, are there incentives that can be creative that make that more likely to occur? Or are there policies that can be adopted that can get the two sectors to work more closely than they have historically?
I think that's a great question, and I do think that there are opportunities there that are untapped. We usually don't point our public health departments in the direction of community health centers or primary care. We usually don't reimburse our primary care providers and point them in the direction of public health. But those are two sectors that, and there have been a lot of great connectivity and advances over the years. But I think there's much more that can be done there, John.
Well, certainly primary care and public health both have prevention at the center of what they do. And I think that there's a lot of synergy there. And I think that there are places where there are really well-developed relationships around specific issues, whether it's dealing with undernutrition and food deserts, or and also in positive things like enhancing maternal outcomes. We've seen a lot of examples of healthcare systems, particularly primary care and public health, working together towards common goals. What we have seen, I think, in COVID is a real gap, and a place where we should be focusing some energy is in the long-term care and home care area, where I think we really need to be investing in workforce, we need to be investing in technology, and there's an opportunity for public health and healthcare to work together. I think healthcare also really adopted some technologies quickly during COVID. You saw an incredible rise in the use of telehealth, and we could apply that in so many places in public health. So I think that there's places where technology and lessons can be shared, and training could exist as well.
You know, in our last few minutes, I want to try to address two remaining questions about public policy and its role. But I want to start by returning to the comments that you each were making about the importance of equity and the importance of centering efforts to overcome racism and discrimination at the core of the work that we're doing. And so, you know, I guess I'd ask you, what are the concrete ways that we can emphasize that work, embed that work within the work of the public health sector and other sectors it's working with, including healthcare? What does it really mean to make equity at its core, at our core?
That's such a good question, John. And I think that there's probably many ways to answer it, but one that I would just sort of throw out first is that as organizations, we have to identify and communicate very clearly our equity principles, and then begin to hold ourselves accountable for how those are getting built into every aspect of the work that we're doing. And it's not a one and done kind of phenomenon, you know, like take a class or, you know, do an all day, you know, workshop. You know, those are important ways of, you know, educating and exposing ourselves and expanding our understanding. But it's really in the work. How do we do our procurement? How do we do our hiring? How do we do our contracting? How do we think about who's eligible and who's not for different kind of grant opportunities? What's included in the grant app? You know, the applications. What are required? So to Mary's point about what's required, you know, for a role, you know, like is a college education, you know, a college degree rather really required for a role? We have to really interrogate or reflect on assumptions that we've made around how, you know, what are the ways that we have to work. And some of the ways we have to work are habits, but they're not necessarily requirements. And so having that stance of inquiry and sort of that openness and saying, we're going to really examine the different aspects, and then having a set of principles that you can apply so that everyone understands what you're doing. It's not arbitrary, but it's like, you know, we're using these principles to apply.
And John, I would say, you know, there's a lesson that I learned a long time ago is follow the money. and build into some of our programs requirements so that people are not just doing the right thing, but they're also getting compensated for doing the right thing. And that's why I mentioned the Federal Health Equity for All Act. And that's modeled after Ryan White, which is greatly successful. And it's going to be putting investments at all levels of government for programs embedding health equity goals. And so I think you'll start to see a demonstration of effort with programs like that. We certainly have seen it through our health and all policies work here in California, cutting across every different department, including transportation and housing.
Yeah, I agree. I think you have to be really intentional about embedding health equity in all of the areas that we've talked about. Data comes to mind as one of the most important. Unless we have data with respect to disparities and inequities, and unless we can collect them, we're not going to be able to address some of these challenges. The Robert Wood Johnson Foundation has recently been doing great work in that area. So I think being intentional about this and really embedding it, whether it's workforce or whether it's financing related issues, as Mary is saying, whether it's data, whether it's with our partnership related activities, ensuring equity is front and center in all these areas, I think is critical.
Well, we've got only about a minute and a half, and the three of you have so much to say and are so thoughtful. Rather than ask a question, I think I'm just going to ask if each of you has maybe 30 seconds of comments, issues that may not have been raised that you want to put on the table for future conversations, perhaps. Any closing thoughts?
I have one, and that is the expansion of Medicaid is so critically important to be able to address health equity in this country, to be able to deal with chronic disease as well as acute pandemic issues. And so I would say we have to pay attention to making sure that we see Medicaid expansion and that we prioritize that includes comprehensive care. We haven't spoken about mental health, but the pandemic showed the critical nature of mental health.
Yeah, very true. Lauren, Anand, your thoughts?
I guess I was just going to go back to this piece around excellence in strategic and communications and being able to describe the work, to be able to address concerns. I think in some ways, sometimes we've been caught a little bit back on our heels with some of this and not being as forward. And I think that, for example, the work that the Public Health Communications Collaborative that the CDC Foundation, Trust for America's Health, others are involved in is an example of really supporting that. So I think that getting ahead of things with really powerful strategic communications, I think, is important.
I'm so glad you raised communications. Thanks so much. And Anand.
Yeah, I think I'll just end it back to your initial question, John, about public health infrastructure and the need for sustained long-term investments. And it's data, it's surveillance, it's laboratory capacity, it's IT. There's so many aspects to that. But without a long-term commitment, it's very difficult for the public health system to address or to help and try to address any challenge. There is some legislation right now in the Build Back Better Act that would provide a down payment to support our public health infrastructure. It's not everything that's required, but it'll be interesting. I've been, over the last 6 months in Washington, D.C., I've been waiting for public health and infrastructure to be used in the same sentence. We were talking about everything else with respect to infrastructure, but public health, we take it for granted every single day. It's absolutely a part of our nation's infrastructure, and people should be talking about that when we talk about infrastructure. So I hope that there will be some more federal support for our nation's public health infrastructure.
Maybe everybody in public health has to raise their voices and demand that we're being heard at the table.
Public health and healthcare and our other partners, indeed. Well, I want to thank the three of you. You know, this has both been a wonderful conversation because you all are so smart and insightful and really are using your vast experience to think about where we need to go. It's also been one of the most frustrating because it's really difficult to have such an important conversation within the constraints of what we always have to do when we have limited time. So hopefully we've piqued the interest of those who are listening, and they'll be following up in terms of many of the issues that have been raised. And so again, thanks to the three of you. And Ceci, I'm turning things back over to you.
Thank you, John. That was an incredible conversation. I want to thank you for moderating the discussion, and I want to also thank the panelists for sharing their time and insight with us. And I want to thank our audience members for tuning in. We'll be emailing a link to the recording, and we'll also be posting the recording of the event on our website in the coming weeks. But before we go, I'm going to turn it over to our final speaker, Dr. David Grossman, who'll be offering his own reflections on the conversation that spanned over 2 events this week. Dr. Grossman is a pediatrician and interim senior vice president of social and community health at Kaiser Permanente. He leads Kaiser Permanente's social health strategy in partnership with Permanente Medical, with the Permanente medical groups, and he leads the organization's public health advocacy and COVID-19 response. Dr. Grossman, Dr. Grossman leads the organization efforts to advance our social practice that connects members with social services, programs and resources to alleviate food insecurity, social isolation, and other social needs, as well as to achieve equitable health outcomes for the communities we serve. So thank you for being with us today, Dr. Grossman, and I'll hand it over to you for your final word.
Thank you very much, Ceci. First, on behalf of Kaiser Permanente, I wanted to add my thanks to and deep appreciation to the speakers and also the moderators of this panel, as well as our previous one this week. You guys have been terrific. We've heard from a really deeply experienced and insightful set of leaders and have heard some, I think, very robust ideas and themes expressed. Many, if not most of these ideas, I think are truly actionable. So we all know that this is a critical policy conversation that needs a lot more attention and focus by our nation's policymakers, state policymakers too, and also the public. And the conversation is timely given the Bipartisan Policy Center's new report, as outlined by Dr. Perek, and we also know that more is yet to come. So we convene this panel because KP, Kaiser Permanente, does deeply care about the future of public health. We believe that healthcare needs to be at the side of public health as a key partner, supporting its critical work in so many different ways. And I just wanted to really highlight a few of the number of key points that have come across over the last several days in these conversations. First, the pandemic has revealed the need for a much enhanced infrastructure. We've heard a lot about that. We have a workforce that's undervalued, overworked, and it's all a result of many years of underfunding by state and local authorities, something that clearly needs addressing very fast, and fortunately is being addressed with some of the recent legislation. We also need a public health structure that can flex up rapidly in times of emergent need, and we need actionable data systems and interoperability so that data and also analytics can flow in real time across systems using common measures. We also heard about the need to address the complexity of the oversight, finance, and also the operations of our nation's public health system. And then in addition to that, we also heard about the importance of relationships and partnerships with key community institutions, businesses, and most importantly, as we just heard today, the public. That for the public health to operate effectively, we need really long-standing, trusting relationships. Public health needs to refocus on its key customer, the public. And as the public's trust with public health builds, so will trust with policymakers. Relationships with healthcare, as we've heard about, are especially important. And we heard from one of our speakers on Monday about how that mattered so much for her in her local health jurisdiction in Seattle as the COVID pandemic unfolded. Communications is at the foundation of trust and relationships. And we heard about the importance of honing messaging and curating the messengers when it comes to talking with the public and with policymakers. We heard that we need to be facile storytellers and training our workforce to be more adept in communicating with the public on every channel. We also heard a lot about the criticality of using a lens of health equity in all public health work and the need for public health to assert itself with policymakers and the public in prioritizing and focusing on vulnerable and lesser advantaged communities. Stronger community relationships matter here too so much. And the public health's credibility with communities of color needs significant strengthening. Addressing, as we just heard from our speakers just a few minutes ago, addressing the underlying social determinants of health, like housing and food insecurity, and also digital equity, is thankfully getting more attention by healthcare, but needs much more focus by everyone, including our policymakers. We heard about the fact that public health has, throughout this pandemic, been fighting a multi-front war. Though COVID has been front and center of efforts by public health, many people are not really aware that there are other major epidemics that are co-occurring, like violence, like harm from drugs, like mental health conditions that underlie many of these deaths. And so public health must be outfitted and prepared to fight disease and injury on multiple fronts simultaneously. But before we start the rebuild, let's acknowledge that our public health troops are hurting very badly. They're under attack, as we heard, and leaving the workforce in unprecedented numbers, especially our public health leaders. So that means we must work to bring some healing and trust back to these incredibly valuable workers who've saved literally millions of lives through the work that they've done. The community needs to really rally behind public health and healthcare, along with other communities and stakeholders, must have their back. We must be speaking up for them and with them. So we at Kaiser Permanente look forward to being a part of this emerging dialogue and also the problem solving ahead. We've all learned some very hard lessons and are now ready to lock arms and rebuild our nation's public health system. Thank you all for joining us here today and for being part of this conversation. We are really looking forward to your participation in rebuilding public health across our nation. Thank you again, and goodbye.